we would proceed with some panel discussion about the lens and the technology with Aurolab.
Yes, sir. That will be great because audience also wants to know more about this machine and these IOLs. So I think the fourth surgery was about overview define.
So, Praful,
Yes, ma'am.
okay. Can you hear us?
Yes, ma'am. We can hear you.
Okay. So the question that you asked, that why is it called hummingbird? Did Dr. Piyush answer that question?
Yes.
Oh, so he's answered. Otherwise, Dr. Neeraj was wanting to answer that question.
No, we would like to hear from Dr. Neeraj also.
No, I could not answer because he was in the OT, we were outside. So I think because when I was operating the voice of this machine, it's like a hummingbird. If you have listened to some videos, there are interesting thing. The voice when you are operating, it is like a hummingbird itself. So maybe they have mentioned the name as hummingbird. We can ask the Oro people when we are free. Then we can ask. But that is, I think, the only probable answer according to me. And Dr. Piyush has also joined us into the discussion. Any questions from your side or the audience or anybody else? Dr. Piyush is here. Dr. Lalit is here.
Dr. Piyush, I think, sir, discuss the advantages and all this of this multifocal, but we'd like to hear more about this Auroview EV Toric, that rotational stability. What's your experience? How many is the rotation?
I think this is the only lens which is like with loop haptic, which is available hydrophobic, and this is having like inclination of around 63 degrees. Which make it like more stable in the bag.
I think you have to keep the mic little bit away from you.
Is it audible now?
Yes. It's audible, but it's little bit. AV team, I think you can guide, sir. The voice is cracking little bit.
It's clear now?
Yes, fine.
Okay. So the main advantage of this lens is hydrophobic with loop haptic. I think no other company is having like this kind of such kind of lens available. And another thing is rotational stability. So because of that fenestration in the loop, so normally anti-posterior capsule adhere and there are like hardly any chances of rotation. And I have implanted many lenses and never seen to like. If we compare with mono haptic lenses like mono loop haptic, then the angulation in this lens is around 63 degree, where that is 57 degrees in those lenses. So pretty capsule. So this is the main advantage of this lens.
Dr. Praful, the main highlighting point is the most of the toric lenses available today are coming with the C loop. They don't have the classical fenestration in between. So this fenestration is their main key point, which actually helps the anterior and the posterior capsule to adhere, and the rotational stability for these lenses is truly excellent. Like they just stick on to the axis where they are fixed to.
Thank you, sir. Any opinion about this pneumatic cutter? How far is it helpful? Is it helpful for only anterior segment surgeons, or posterior segment surgeons can also use that?
I can answer this question better. So this pneumatic cutter is useful only for anterior vitrectomy because the cuts are only 1200 cuts. Although in dire circumstances, a posterior segment surgeon can use it, but the cut speed rate is very low. So it is not an ideal proposition for a posterior segment surgeon, especially in these days, because if I remember my olden days, 30 years back, we used to do cutting in a posterior segment surgery with 800 to 1200 cuts only. But now the norm has totally changed. We have cut speed up to 10,000 and even more. So not an ideal proposition, but rarely it can be used. But this is mainly for the anterior segment surgeon.
So, Dr. Piyush, what's your experience with this Auroview Define lenses?
Auroview Define is a beautiful technology. The lens actually gives a near correction up to about a +3 diopters. For the patient's comfort zone, when it comes to glare, it comes to halos and all, it is very minimal in these patients. But my preferred practice is that I use Auro Define mostly for the females or the patient who may not be the night drivers. So wherever I find a patient who needs a better perfection in their vision, I would rather actually prefer a Vivid or a combination of Vivid with Auro Define than preferring the plain Auro Define. But Oro Define in general, the number of rings are not as many as the classical trifocals have. So again, the night glare when the pupil dilates and all is comparatively minimal in this.
Thank you, sir. What about the other products of Aurolab in cataract surgery? I think you said you are using almost all their products routinely.
They have mostly all the ranges, like starting from their lovely microkeratomes and all the microkeratomes we used in the surgery today were by Aurolab. Then the Oro dye they supply, then the viscoelastic, they also have sodium hyaluronate and the cohesive viscoelastics as well. So mostly they come up with the entire product range, whether it comes to the anterior segment or the posterior segment surgeries. Even mostly in the retinal surgeries, with most of the gases, the silicone oil being used in my center are from Aurolab only. The product quality with these companies are quite good, and the best thing is the reproducibility in terms of their quality, like their knives, and if they don't have much of a variation in the products or any kind of undesired adulteration into it.
I think our Dr. Piyush is absolutely right, and I am also using at my own clinic as well as the Healing Touch. Their products are definitely very good and comparable to the imported products, and the cost-wise they are most economical. So they are one of the best products available.
And I can mention a few of these products are like voriconazole and others are available from Oro Labs only. So there are few products which only Oro is manufacturing. So that's pretty good, made in India product, which is like
And
available.
not to mention, because this is an anterior segment thing, but again, their Oro silicone oil and their PFCL and everything, they are also wonderful quality. I am a posterior segment surgeon also. So those products for the posterior segment is also very good.
Since we have another 5-10 minutes left, one question that most of the practitioners who are just beginning, they always think, what should be the cutoff for Toric IOL? What is the cylinder that you consider?
When I started my practice, it was like somewhere around 2 diopter or more. But with this technology, like we can decrease the bar up to 1.25 or 1.5 diopter. So whenever I'm seeing a patient of 1.5 diopter, 1.25 diopter, and then I start getting scans done, and if this patient is suitable, then I ask him or her for Toric IOLs. So I think up to 1.5 diopter is like, it should be the cutoff, and anything like more than 1.5 diopter are ideal cases for Toric IOLs.
And what is the how to center a multifocal IOL at the end of the procedure? What exactly the surgeon must see to be sure that yes, my lens is centered?
I would say that, Dr. Praful, it is not the end of the surgery, but it is the beginning of the surgery which decides that how centered your lens will be. So the key point for that would be having an ideal rhexis. It should be an absolutely round one. The better the centration of the rhexis, the final outcome of the centration of the lens would be the most desired in the end. So the main step, I would say, would be a perfect rhexis, and with the precision of the femto platform, I believe that gives the surgeon much of an ease. So that is one thing. The second thing is a perfect cortical cleanup, because if you are left with any kind of fragments of cortex lying in the bag, they would actually lead to a decentered lens. So a perfect cortical cleanup and a absolute good polishing of the capsule is the desired thing, which I would say that one should aim. Finally, I would say that in the end of the surgery, what you say, a good, I would say, a chamber stability and well hydrated chamber with a stable chamber would actually give you a perfect centration of the lens. Anything you as a surgeon would like to add, I would love, because you are much higher and a more talented surgeon, I would say.
No, sir, it's not like that. But I think both Dr. Neeraj and you are there, so I would like to repeat my question again. In a patient of diabetes, with no retinopathy, what would be your preferred choice? Because Dr. Neeraj still prefers monofocal is the way to go. But what is your
See, I believe most of the surgeons have designed their own protocols. My protocol is that I would look at the age of the patient. I would actually get an HbA1c done for these patients. If I see that the patient has a very good diabetic control, HbA1c is very much normal, I would actually expect that this patient further 20 years down the line also would be having an equally good control. And if the patient at the same time desires a multifocal lens and says that yes, if he has no diabetic retinopathy, I see the control is good, I would educate these patients for the importance of a good diabetic control, and then I would actually plan a implantation of a multifocal lens in these patients. But if at the same time I see a patient recently diagnosed diabetic, not very particular about his or her control, the HbA1c is haywire, I would rather refrain from putting a multifocal, telling these patients that the future can be hazardous.
I would like to add on again, Dr. Praful, you are asking this question again. So, why do you think the EDOF lenses have come? So, I would definitely prefer a vivid lens over a multifocal in such cases. Whenever the choice is there, I will not recommend them a multifocal, even if he doesn't have diabetics. So, he does diabetic retinopathy. So, that would be the choice, because that is why the EDOFs are coming. Otherwise, why will EDOF come if multifocal is the ideal lens? So, we should understand the logic, the physics, or the science behind it. So, EDOF lens, as per today, if it is a diabetic patient and very bad controlled diabetic, definitely multifocal should not be the answer. EDOF, yes, you can still explain because they are the better lenses, and otherwise monofocals still the gold standard, I think. Any other comments, sir?
I would like to add one thing, like we should also check, I usually check 4 parameters in those diabetic patients. One is anemia, hypertension, and lipid profile. Like all these parameters are like, and any of the 2 or 3 parameters are there which are deranged, then I defer multifocal lenses in the patient. EDOF and monofocal are my choices there.
any question for audience? Because I have run out of my questions. Okay, then
I would. You have asked our choice. I would say, what do you follow at the institution level? Like these are the talks, or these are the comments from the private practitioner, which have a peer pressure from the patients as well at times of their demands. But what is the protocol you guys follow at the institutional level, sir?
This question, sir, I put it to both of you because this is the question even the patient keeps on asking us. Because at RP center, diabetes patient, we normally use monofocal only. Even we don't prefer EDOF. So that's the question the patient asks. हम तो 3 जगह दिखा के हैं. They all have said that I can go for multifocal. So why you are saying no? Multifocal should not be put. So that's the question even that we face. But I completely agree with Neeraj sir. There is no harm in putting an EDOF IOL. If some IOL is giving some benefit to the patient, there is no point of not giving that advantage to that patient. But yes, the patient has to be explained everything in the dofuls, the advantages, the risk associated with their multifocal IOL. If the patient is ready to take a chance, then who are we to deprive him that benefit of multifocal IOL?
Very well taken, Dr. Praful. You, I think, rightly explained that if a patient demands and we can actually deliver and we foresee that the patient can do well with the multifocal, why do we deprive him of the technology? And thanks to you, Dr. Praful, I think you very well moderated the session. Your questions were truly excellent and really what would come to any of the ophthalmologist's mind. So thanks to you, sir, for moderating the session. And thanks to Aurolab for giving us the opportunity to show the technology from Healing Touch. Thank you, sir.
Thank you, sir.
Thank you.
Wonderful, Sadri bhai, all of you. And thank you, Aurolab, for taking us one step forward in this Atmanirbhar Bharat.
Yeah, that's right. Thanks, Aurolab. Thanks.
Thank you.
Excuse me, sir. Sir, one question to you. So
Yeah,
if we
please.
are planning for multifocal, do you routinely measure angle alpha and kappa for every patient, or it is for some specific power?
Dr. Jay, aage.
Sir, if the question was audible to you?
Yes,
The
sir.
question
Yes, it
is-
was audible. Angle alpha was audible. Then further anything?
Angle
If-
alpha and kappa.
Ma'am, now with the newer generation of IOLs, we generally do not go into the practice of measuring the angle alpha or kappa. But whenever it's a very high hypermetropia, in those patients, the importance, yes, generally comes up. And whenever I am actually implanting a lens beyond a 26 diopter, I would actually measure these parameters to actually see that the patient does not have those elimination criteria into it.
Okay. Sir, above power 26. Any cutoff of
Yeah.
power or axial length?
Any cutoff of power or axial length?
No, it depends upon the availability of the lenses, because they are not generally available in very high powers beyond, I believe, a 30 diopter. So we can only implant up to the available powers. And secondly, if these patients have a high angle alpha or kappa, they may not be having a perfect vision post-operatively. So I would rather prefer going in for an EDOF rather than a multifocal in these patients.
Sir, I just want to add on to my question. Like you don't routinely measure angle alpha and kappa. So is there any cutoff for measuring angle alpha and kappa, like regarding axial length or regarding power of the lens?
So the question is there any cutoff for axial length and power to measure angle alpha?
No, I would say that we go in for the dioptric power, not exactly for the axial length. I would see that if a patient has a dioptric power more than 26 or a similar one, then I would actually go in for the measurement of angle alpha or kappa. And if they are in the cutoff range, then I would say that yes, we can implant. But if the angle alpha or kappa is larger, then I would actually refrain from implanting a multifocal in these patients. But for the axial length, no, I would say no, ma'am, because it is more about the optics. It is about the implant, the thickness of the lens, the centration, which actually defines it.
Thank you, sir.